Every 15 minutes in the United States, a newborn who experienced prenatal substance exposure presents with the clinical signs of substance withdrawal. This withdrawal is known as neonatal abstinence syndrome or newborn opioid withdrawal syndrome, depending on the substance exposure type. The prenatal substance exposures may be prescription, misused prescription, or illicit substances. In 2020, 46% of Tennessee newborn withdrawal cases involved prescription medications, 32% prescription misuse, and 19% a combination of illicit and prescription substances. The overall incidence of newborn substance withdrawal in the United States is around 8 per 1,000 birth hospitalizations. And in rural areas, such as Appalachia, those numbers often surpass 60 per 1,000 birth hospitalizations. Newborns with prenatal substance exposure may experience symptoms of the central nervous system, such as high-pitched, inconsolable crying, autonomic nervous system, such as increased respiratory rate, and the gastrointestinal system, such as vomiting. The current knowledge of neonatal abstinence syndrome, or NAS, and newborn opioid withdrawal syndrome, or NOWS, is based primarily on research in mother-infant dyads from urban areas where the mothers were attending comprehensive substance use treatment. However, there is a gap in understanding the mother-infant dyads with substance exposure and newborn withdrawal in rural areas. My colleagues and I are working to address this gap. In this presentation, I will discuss two of our studies that explore substance exposure in mother-infant dyads in Appalachia. The first is a study completed with colleagues at the University of Kentucky that examined the recent and lifetime characteristics of pregnant individuals with substance use disorders and compared them based on urbanicity. In our study, 63% of individuals were from Appalachian counties. This study was observational in nature. Data were collected using electronic medical record review and maternal interview. Mothers were interviewed for maternal demographics, pregnancy history, as well as by using the Addiction Severity Index. The Addiction Severity Index includes questions regarding the mother's medical status, employment status, substance use current and past history, legal status, relationships, personal mental health history, and family medical substance use and mental health history. Study participants were women with substance use disorders whose newborns were admitted to the University of Kentucky's Regional Medical Center with newborn substance withdrawal. Consent was received from 120 participants and 93 completed interviews. The mothers were recruited between December 2017 and September 2020. The inclusion criteria included the use of opioids during their most recent pregnancy. Exclusion criteria included mothers of newborns not likely to survive, mothers of newborns with medical concerns beyond withdrawal, and maternal use of cocaine. Significant differences included greater perception of inadequate prenatal care in individuals from urban versus rural areas, greater use of amphetamines or methamphetamines in the month prior to delivery by urban individuals, and longer periods of substance use abstinence among individuals from rural areas. Our findings differ from the current understanding of mothers with substance use disorders. And while we recognize that our results may differ with a larger sample, our findings do suggest the use of caution against negative stereotyping of pregnant individuals from rural areas. In the second study I will discuss, we examined the trajectory of known newborn substance withdrawal symptoms over time to assess how relevant each symptom is once the infant begins receiving medication to manage withdrawal symptoms. This was a single-site retrospective study conducted using chart review on infants diagnosed with neonatal abstinence syndrome between 2018 and 2020. We used a generalized estimating equation with within-subject correlation to estimate the daily item prevalence for known withdrawal characteristics. Study participants included infants with any prenatal opioid exposure, a gestational age of greater than or equal to 35 weeks, no medical conditions beyond withdrawal, and who met the criteria for medication to treat NAS. And we had a sample of 182 infants. Significant results included those of both the central nervous system and the gastrointestinal systems. Of the central nervous system symptoms, continuous high-pitched crying and duration of sleep after a feeding were the best predictors of infants who would require treatment for greater than 12 days. For our gastrointestinal system, symptoms of watery or loose stools, regurgitation, or projectile vomiting were still notable and sporadic throughout the course of treatment using medication, and those were also the best predictors for infants who would require treatment for greater than 12 days. This study is likely of most interest to medical facilities who are choosing and implementing newborn withdrawal severity assessment tools. Our results suggest the use of caution when choosing the correct tool that you want to implement within your facility, and making sure that those significant manifestations, crying, sleeping, vomiting, and loose or watery stools are included. So where are we going from here? My goal now is to look at biological markers and social determinants of health that can assist with the identification of newborns with severe withdrawal. Thank you.